Okay. Well, thank you very much for inviting me to speak to you today. What I thought I would talk about today is why ICU and not why ICU, and specifically focusing on talking about palliative and end-of-life care. I don't have any disclosures, and I'm going to show you some research that's been funded by the National Institute of Nursing Research in the U.S., as well as the Patient-Centered Outcomes Research Institute in the U.S. And what I thought I would try to do today is answer 4 questions. First, what is palliative care and how do we describe it to others so they understand us when we talk about palliative care? Secondly, what are advanced directives and advanced care planning and how can they help us? How can we measure and improve communication about palliative care? And then finally, what can you or we all do to improve this? Okay, so this is a definition of palliative care that I like very much. This definition was developed by the Center to Advance Palliative Care within the United States. And they define palliative care as specialized care for people with serious illness. They don't talk about terminal illness, they talk about serious illness. It's focused on providing patients with relief from symptoms and stress of a serious illness, whatever the diagnosis. The goal is to improve quality of life for both the patient and the family. It's provided by a team who work with a patient's other doctors to provide an extra layer of support. And palliative care is appropriate at any age and at any stage of a serious illness and can be provided together with curative treatment. So this is a very broad definition of palliative care. It does not talk about end-of-life care or terminal illness, but rather serious illness. And this idea, I think, is very important, that we view palliative care as much larger than end-of-life care and hospice care. Palliative care is care focused on improving quality of life for all patients with serious illness and their family members. End-of-life care is an important part of palliative care, but it's not all of palliative care. And end-of-life care is care focused on those who are in their last phases of life and actively dying. And then hospice care, at least within the United States, is a term that's specifically used for one model of end-of-life care for patients who do want to give up curative treatments and focus only on comfort. But that's just one part of end-of-life care, and end-of-life care is just one part of palliative care. And if we see palliative care and end-of-life care as the same thing, then we miss enormous opportunities to provide good quality palliative care to patients with serious illness who are not actively dying. So what do Americans think about palliative care? Because there was a lot of concern that Americans did not believe in or want palliative care. But in fact, that's not true. This is a survey that was done with a national sample. They asked people in the US, general public, is it important that patients and families be educated about palliative care options available to them and describe to them what palliative care was? 97% agreed it was important. They also asked how important is it that palliative care be a top priority for the healthcare system, and 96% thought it was important or very important. So I think there's a lot of fear and concern that people in the general public won't be accepting of palliative care, but at least in the US, when you explain it to them, they are very accepting of it. I also like to make a distinction between primary palliative care and specialty palliative care. So primary palliative care is care provided by all clinicians, doctors, nurses, social workers, spiritual care providers, and others who care for patients with serious illness. This includes family practice doctors, oncologists, pulmonary doctors, all doctors who take care of patients with serious illness provide primary palliative care. And then specialty palliative care is the care provided by palliative care specialists, clinicians with additional training in palliative care. And I believe that if we really want to make sure that patients get the best palliative care possible, we need to improve both primary palliative care and specialty palliative care. That we can't do it with either one alone, but really need to do it with both. I'm going to show you a little bit of data from research studies that looked at the value of palliative care. And this is one of the most important studies that has been done. This is a study that was done at one hospital in the US, the Massachusetts General Hospital, one of the most famous hospitals in the United States. And what they did was that they did a randomized trial. So they identified patients who had metastatic non-small cell lung cancer and then divided them into two groups. One group got routine care at one of the best hospitals in the US. The other group got that routine care but also saw a palliative care specialist early on, right after diagnosis of their cancer. And then they followed patients to see how the patients in the two groups did. This is a graph that shows quality of life for these patients. The TOI is a quality of life score. And the patients who were randomized to early palliative care had higher quality of life than the patients who got the routine care. So palliative care improves quality of life. They also measured patients' levels of depression using two scales, a scale called HADS-D and a scale called PHQ-9. And these scales, these are surveys that measure depressive symptoms, and they found that the group that got randomized to early palliative care had less depression than the group that got routine care. And then they also looked at how long these two groups of patients survived. And this shows a survival curve comparing the early palliative care in red and the standard care in blue. And what they found was that early palliative care resulted in improved survival. Patients lived longer if they got palliative care than if they got routine care. This finding was a surprise to everyone, including the people who did this study. They did not expect palliative care to improve survival. They did expect it to improve symptoms and improve quality of life, but they did not expect it to improve survival. And it's not exactly clear why it improved survival or what the palliative care doctors did that improved survival, but it's likely that it's partly because they controlled symptoms, so patients were more comfortable, and if they're more comfortable, we know in hospice that patients live longer if they're comfortable. It's also likely that patients who saw a palliative care doctor and was able to talk about their diagnosis, their prognosis, and what was happening to them were less likely to receive chemotherapy, toxic chemotherapy at the very end of life. And that chemotherapy probably actually reduces survival if people have not responded to the first attempts of chemotherapy. And so when this paper was published, there was a lot of attention to this, and a lot of people said, well, what did these palliative care doctors do that resulted in all this improvement? And so the people who did this study went back and they looked at the medical notes that the palliative care doctors wrote about the patients that they saw in the group that got randomized to palliative care. And they found that what these doctors did in seeing in seeing these patients really fell into 7 elements. First, relationship and rapport building. Second, addressing symptoms. Third, addressing coping. Fourth, establishing illness understanding. Fifth, discussing cancer treatments. Sixth, end-of-life planning for patients and their families. And then finally, engaging the family members in all of these aspects of care. This is what the palliative care clinicians did as part of this study. And most of this, there's addressing symptoms, but other than addressing symptoms, all of this focuses on communication. It focuses on talking to patients about what's happening to them, listening to patients about what's important to them, and including the family. This study, as well as other studies like it, have led to a dramatic rise in palliative care programs across the United States. This graph shows the number of hospitals that have a palliative care program from 2000 to 2010. In 2000, it was about 40% of hospitals had a palliative care program. Now it's about 85 or 90%. So it really has increased dramatically. And I know I've been coming to Bangkok now for about 8 years, and the first time I came, there were no palliative care programs. And now I was very excited this time at Chulalongkorn University to be introduced to the palliative care team, a large group of clinicians providing palliative care in the hospital, and to visit their office and see where they do their work. And so in Thailand also, there has been increase in palliative care. So that's a little bit about palliative care. And now what I'd like to do is talk a little bit about advanced directives and advanced care planning and how we can think about bringing this information to the general public and have them begin to think about being prepared for the kind of care they want if they become very ill. One question that comes up is, who should bring up a discussion about palliative and end-of-life care for a patient who has a serious illness? If you ask patients, most patients would say the doctors should bring it up. If you ask doctors, most doctors say the patient should bring it up. All right? There's a problem here, right? Nobody wants to bring it up. And I think this is an important problem and one that we've been trying to address in the United States, and we've seen really very dramatic changes over the last 5 or 10 years. So what can people do if they want to ensure that they receive the care they want with a serious illness? In the United States, there have been advanced directives in existence for over 20 years. The most common advanced directives are the living will and the durable power of attorney for health care. More recently, there's also a new type of advanced directive, which is called the Physician Order for Life-Sustaining Treatments, or the POST form. And I'll talk a little bit about each of these. But I think it's very important to see these advanced directives as being part of a process that's called advanced care planning. Advanced care planning is the communication that patients have with families and with their doctors about their goals, their values, and their preferences, and what's important to them. Advanced directives are an important part of advanced care planning, but I'm going to show you some data that if all you do is advanced directives and you don't do the advanced care planning, it doesn't work. You really have to do both. So this was an early study that was done published in 1992, where they did a randomized trial of offering advanced directives amongst over 200 elderly patients. These were patients with a life-limiting illness, and they were randomized either to physicians offering advanced directives or usual care. Half of the patients were offered advanced directives. Most of them preferred that there be some limitation on the kind of life support, aggressive care they got at the end of life. They wanted to focus more on comfort than living as long as possible if their quality of life was very poor and they were uncomfortable. And 2/3 of them, 66%, completed an advance directive. So this was pretty successful in terms of introducing advance directives and getting patients to complete advance directives. But that was all they did. There was no communication with the family. And this was really happening before we understood how important advanced care planning is as part of advance directives. So the results of this study was that the group offered advance directives, the care that they got was exactly the same as the group that was not offered the advance directives. Advance directives by themselves made no difference in the care that patients received. So why is that? Why is it that advance directives by themselves are not successful? There was a lot of excitement in the US about advance directives at this time. In fact, the US Congress passed a law that said that all hospitals had to ask every patient admitted to the hospital if they had an advance directive. So they really thought advance directives were going to fix the problem of patients not being able to get the care they want at the end of life. But there are a number of reasons why advance directives by themselves are not enough. It's often very difficult for people to predict what kinds of decisions they might have to make if they get very ill. And it's hard to know what the circumstances will be and what they might choose in those circumstances. In addition, predicting what we might want in the future may be limited by changes. They may be changes within ourselves that as we get older and become more ill, we may adapt and get used to things that we used to think we could never tolerate. You hear a young person say, well, if I had to live in a wheelchair, I would never want that. Then they get injured, they're in a wheelchair, and actually they enjoy their quality of life. So they adapt, and it's hard to predict how each of us will respond to that. There may be other changes in the medical situation, our emotional situation, our social situation that may change the kinds of decisions we make. And so it can be very difficult to know exactly what we would want in the future when we don't know what the circumstances will be. And then finally, patients often want their family's circumstances and their family's preferences considered. And I think that's very important. And I think in the Thai culture, that actually may be even more important in the US, where the family is a very important part of decision-making process and how decisions are made. And so we also need to factor in that and what the patient feels they would want to have, how they would want the family involved in making these decisions. I like to tell the story of my wife and I. We have very similar preferences about the kind of care that we want if we become very ill. And we wouldn't want to be dependent on machines, living in a hospital, if we couldn't interact with our family and enjoy our lives. We wouldn't want that for ourselves. So very similar. But we're very different about our family's preferences. My feeling is that if she has some reason that she wants to keep me alive on a machine in a hospital, as long as I'm not suffering, I'm okay with that. Her feeling is very different. And she says if I do that to her, she'll find a way to come back and kill me. Right? So very similar preferences, but very different in terms of how we want our families to be involved in changing these decisions that we've made. So I showed you a study that said that advanced directives by themselves didn't work. Here's a study that says advanced care planning with advanced directives does work. This was a study that was conducted in Australia. They identified over 300 patients over the age of 80 who were hospitalized and randomized them either to advanced care planning by a trained advanced care planning facilitator, not a doctor, but someone trained to do advanced care planning, or usual care. Of the patients who are supposed to receive advanced care planning, 80% of them did, and 56% completed an advanced directive. So this is similar to the other study that I showed you in terms of the proportion who got the intervention and who filled out advanced directives. The facilitators used an approach called respecting choices that's done not by the physician, but in collaboration with the physician. So the physicians were involved and supported the advanced care planning. And families were present for most of these discussions. In 72% of the time, family members were actually there. So it's not just filling out a piece of paper separate from the family, but it actually involves the family in the process. And these sessions took an average of 60 minutes, so they took a long time. The other study showed no difference in the care received. This showed pretty big differences. So of the group that got advanced care planning, none of them died in the ICU compared to 14% in the control group. They also found that this advanced care planning had significant benefit for family members. They were much less likely to have psychological symptoms like post-traumatic stress disorder, depression, and anxiety in the group that got advanced care planning. And the family members were also asked to rate their satisfaction with the death, the patient's death, as well as satisfaction with care, and it was much higher in the group that got advanced care planning. So advanced directives are helpful if they're done in the setting of advanced care planning. Well, why might that be? Well, advanced directives are focused on the document, on a static piece of paper that's difficult to adapt to real-life situations, and it's often done without a careful discussion of the patient's goals and values. Advanced care planning offers the option or the possibility of having a discussion of goals and values and helps to prepare patients and their families to address these situations when they really arise, as opposed to just having this piece of paper that now may be hard to interpret. So I'd like to talk a little bit about how we measure and improve communication about palliative care. What we found in a number of studies in the US was that doctors are generally not very good at this. They need additional training. This was a study that looked at audio tapes of 87 patient-doctor discussions, and they found that doctors spent 73% of the time talking and only 27% of the time listening to patients. Doctors rarely brought up discussions about the patient's values or goals, less than a third of the time. And they rarely asked patients to explain the reasons for their preferences or to talk about what was important to them about their quality of life. We were interested in developing a better understanding from patients' perspectives of what they saw as important skills for physicians in talking about palliative care and end-of-life care. And so we did studies with patients with a number of different illnesses as well as families and physicians. And we developed this model based on what patients and families told us about the important things about doctors' skill at talking about palliative and end-of-life care. Communication skills was very important. Communication with patients, educating patients, and including the family, as well as cognitive skills, the ability to understand, to be competent as a physician and to understand pain and symptom management. Affective skills, being able to provide emotional support. Keeping the patient's values at the center of the care we provide. And then having a system and a team approach that keeps the patient at the center. This is what patients told us was most important. In terms of the communication piece, that one box on communication, what patients told us was most important was that we listen to them. Not that we talk to them, that's important too, but the most important thing is that we listen, that we encourage questions, that we talk with patients in an honest and straightforward way about their illness, that we give bad news in a sensitive way that shows that we care about what's happening to them, that we be willing to talk about dying and what that might be like, but that we be sensitive to when patients are ready to talk about death. Because not all patients are ready, and we need to be sensitive to that. So we were very interested in saying, okay, if that's if that's what's important to people, how do we measure communication so we can then figure out how well doctors are doing and how to make them better? And I think that there are opportunities to audio tape, and we've done some of this work where we audio tape these discussions and analyze them. We also have developed surveys that allow us to give a patient or a family member a survey and have them rate the communication of their provider. And so when we developed these surveys, we were interested in knowing whether doctors' own impression of how good they are at communicating about palliative care matched the patient's impression of how well the doctor did. Because if doctors are pretty good at knowing whether they're good or not, then we don't have to survey patients. We can just ask the doctor, find the doctors who are not very good, and train them. And so this shows how the patient rated the doctor's communication about end-of-life care on the vertical axis, on the horizontal axis, how the doctor rated their own competence. And what you can see is there's absolutely no relationship between. There's no correlation, there's no association whatsoever. Doctors are terrible at knowing how good they are at this. We cannot rely on them to decide, oh, I'm not very good at this, I need additional training. So we developed a training program, and this is a recent publication that shows this training program. This was a 5-year study that was funded by the National Institutes of Health, and specifically the National Institute of Nursing Research. And in this training program, we wanted to train both doctors and nurses together. So we had internal medicine residents and nurse practitioner students together in these training programs. We did this at 2 places in the US, the University of Washington in Seattle and the Medical University of South Carolina in Charleston, South Carolina. And the training program occurred in 8 half-day sessions. These were 4-hour sessions with doctors and nurses together in small groups, about 10 doctors and nurses combined, and 2 faculty members. And there was some lecture, but most of the time in these training courses are spent letting them practice communication with actors and actresses trained to act as patients and family members. And we did this because we believe strongly that communicating about palliative care and end-of-life care is a skill like driving a car. And you can't learn how to drive a car in a lecture or by reading about it in a book. You have to have a chance to practice. Communication is exactly the same. We showed that in fact, these residents, these doctors and nurses got better at these communication skills, assessing a patient and whether they're ready to talk about end-of-life care, asking for an invitation to give bad news in a situation where they have to give bad news, providing empathy and compassion after giving the news, stating that we'll support the patient throughout their illness, and exploring the patient's emotions. All of these skills improved after the workshop compared to pre or before the workshop. We also surveyed a lot of patients that were cared for by these doctors and nurses, and it was difficult to show improvements in the communication skills across all patients. One of the things that happened, though, was that we did see a little more depressive symptoms or sadness in the patients who were randomized to have a doctor go through the intervention. So it did seem like talking about this with patients did cause a little sadness, and I think we need to understand that. I'm not sure that's necessarily a bad thing if what that's doing is it's encouraging doctors to talk with patients about what's happening, as long as they provide the support that patients need. We also looked at different subgroups, and we did find that if we looked at the patients who were the sickest, that they did rate their doctor's skills as higher if they went through this training program. So we do believe the training program improve skills, it was only really seen by the patients who were the sickest in the study. And so we found that this kind of training can improve physicians and nurses' training skills. I didn't show you this, but it also improves their self-assessment. We didn't see overall improvements in patient ratings, and I think that's part of the problem. Sometimes it's very difficult for patients to be able to rate this kind of communication. And as I mentioned, we also did see some slight increase in depression scores, which I think we need to understand and take into account when we want to encourage doctors to talk with patients about their illness and their prognosis. So finally then, what can we all do around this to make things better? First, I do think that these documents like living will and durable power of attorney for healthcare, where the patient gets to say who they want to make decisions for them if they're too sick to speak for themselves, I do think they're important as long as they occur with advanced care planning. I know in Thailand, the living will is relatively new, advanced directives are relatively new, and they're not being used very much yet. And what I would encourage you all, as you think about ways to promote this, is to not make the same mistakes we made in the US and think that the documents are going to be the answer. They really have to be part of an advanced care planning process, and we need to work to raise awareness for the general public as well as for doctors and nurses for the importance of advanced care planning. I also think that the PULSE form, this physician order form for life-saving treatments, can be very valuable, and it's something to think about down the road after there's an acceptance of advanced directives and advanced care planning. I think the advanced directives can be very helpful as a tool for raising these discussions. They're also good for some very specific circumstances. If there's a specific treatment that a patient knows they don't want, or if they want to be able to say, I have a big family, but this is the person I want to be able to make decisions for me because they understand me best, then I think these documents are extremely important, and we should encourage people to complete them. We also know from studies in the US that if patients have advanced directives, even early on, when they didn't change the care the patients got, they actually did make things easier for the family. It improved families' symptoms of anxiety and depression and improved their outcomes if the patient had a living will. And so the other thing we can tell patients is that this is something that if you do can actually help your family. There are a number of tools available to help people think about advanced directives and advanced care planning. One of the ones that gets used a lot in the US is this one called 5 Wishes, which is available online for free, although you have to register to get it. And it provides a format for talking about and documenting advanced directives, and I think it's a helpful document. Another program that I want to highlight as being very helpful is something called the Conversation Project. This is also a wonderful website that's available, and you can download a free, what's called a starter kit. And this is a program that's really tried to increase awareness of advanced care planning throughout the US and encourage people to have these conversations with their family. And so you can download this starter kit and then have a discussion with your family. I did this with my parents recently who are elderly, and even though this is what I do for a living, we had never really talked about what they wanted. And I thought I knew, but I wasn't sure. We downloaded this starter kit, and it was really a very helpful way of getting this conversation going. The website is up there. It's just www.theconversationproject.org. And as I say, it's free for download. It's been translated into Spanish, French, and Mandarin. I don't think it's been translated yet into Thai, but maybe that's something that this group could take on. So I mentioned the durable power of attorney for healthcare as one of the types of advance directives, and I think it can be very helpful in allowing people to say who they want involved in this decision if they're not able to. If you don't have an advance directive, then who decides is your doctor and your family. But I think for many people, if they want to have a say in who decides, if they're not able to speak for themselves, this document can be very helpful. It allows them to pick someone that they trust to make these decisions. And it's very important that if they're going to do that, that they have a discussion with that person. And the conversation project can be a good way to do that, so that that person is prepared to take on the responsibility that they've given them. I mentioned the POST form, and I wanted to just show you that quickly. This is the physician order form for life-sustaining treatments. The advantage of this is that we currently can write a do not resuscitate order in the hospital, but if the patient leaves the hospital, that's no longer effective. In the US, these documents are effective across all settings, in the hospital, in a nursing home, or in the patient's home. They're equally effective. And I think they're very important if someone knows that they don't want a specific kind of life-sustaining treatment. And this is the form. I know it's hard to read, but it's a form that a doctor and a patient fill out together with a discussion, and the doctor signs it, and it becomes an order that then can be followed in any setting. So I think if we're encouraging people to have these kinds of discussions, it's important to encourage them to think about how to prepare for that, thinking ahead of time of who should be there for the discussion, which family members, which doctor, what do they want to know, and making sure that they have the documents that they want to fill out, that they bring that to the discussion. I think it's very helpful to encourage people to think about the things that they might want, specific treatments that they do or don't want, and also aspects of their health that are very important to them. Some people say it's very important that I be able to be independent and take care of myself. For others, that's less important. For some people, the ability to communicate with their family is very important, and that may be less important for others. And it's also important to consider adaptation that I mentioned earlier, and to realize that even the things you may feel now might change over time, and to be prepared for that. When people are having a discussion with their doctor, it's very important to encourage them that if they don't understand something, ask the doctor to repeat it, use plain language, and even ask the doctor to slow down if they're talking too fast. It also can be helpful to ask if you, the patient, can repeat what you've heard to make sure you fully understand it. And doctors hopefully will be patient enough to listen to that. And then it's also okay to ask the doctor's opinion and recommendation, even if they don't offer one. Some doctors feel like they shouldn't offer a recommendation, but I think if a patient wants a recommendation or a family member wants a recommendation, they should ask for it. In terms to what to discuss with a doctor, I think it's very important to talk about our personal goals for healthcare, what's really important to us, about our quality of life. It can be very helpful to talk about preferences for life support and cardiopulmonary resuscitation. That may include some patients who say, I don't want any life support or CPR at all. In my experience, that's not very common unless patients have very severe illness and a poor quality of life. What's more common is for many patients to say, well, I would want life support. I would want to be in an ICU, for example, to be on a ventilator or a breathing machine for a short period of time if I could get better from that, but not if I couldn't get better. And then there are even some patients who would say they would want long-term life support even if they had no chance of coming off the life support. And I think that's important to understand about people as well. It's also important to talk about the situations in which you would not want life support. Some of these I mentioned, being unable to live independently or communicate with loved ones, or to be confined to being on prolonged or indefinite life support in a hospital for the rest of your life. As I mentioned, I think certainly in the US, the most common thing people say is that they will want life support for short-term irreversible illness. And many people say they would not want life support if it meant they could not live out of a hospital off of machines, or if they were not able to communicate with loved ones. So in terms of whether we should want to be in an ICU or not be in an ICU, I think it's important to understand that intensive care involves aggressive treatment that can be burdensome, can be uncomfortable. Although we have medications to try to keep patients comfortable, it can still be uncomfortable. And that patients are dependent on that life support technology to keep them alive. But many patients will recover from the illness that put them in the ICU and restore them. That ICU can restore them to their prior quality of life sometimes, or sometimes not quite to that quality of life that they had before, but to a quality of life that they would find acceptable. And so I think the important questions are, in terms of the question of whether to go into an ICU or not go into ICU, what are the chances of survival? And what are the most likely outcomes? The best case scenario, the worst case scenario, and the most likely. And with that information, I think it's possible for people to think about answering this question of whether or not they would want to be in an ICU. But for many people, it would depend on the answers to those questions. The ICU is a very foreign environment. It's very stressful for patients if they're alert. It's very stressful for family members as well, to see patients dependent on machines, to see all this machinery. And I think it's important to understand that stress and to try to prepare people for it if they have a loved one in the ICU that they're going in to see. But again, many people would be willing to go through this if we could keep them reasonably comfortable during it, and there was a reasonable chance that they would come out of it with a quality of life that they would find acceptable. When we have these discussions, I think it's very important really not to focus as much on the treatment, the ventilator, cardiopulmonary resuscitation. I think it's more important that we focus on the goals. What are the goals? Are the goals to live independently, to have a good quality of life, and what does that mean to the patient, being able to communicate with others? Goals, I think, are more important than specific treatments, and all too often, especially I see this in the US, where doctors focus on talking about the treatments. That's not what's important to patients and families. What's important to them is the goals. And then we can decide, once we know the goals, we can decide, okay, can these treatments help us meet those goals? I think when we're finishing a discussion on end-of-life care, it's important to encourage patients and family members to take a minute to think if they have any questions, to summarize a discussion in your own words and ask the doctor or nurse if we got that right. And also, if there are things that aren't clear, to ask if we might be able to think about it for a while and meet again later to discuss it more. I think it's important to acknowledge that talking about end-of-life care, talking about dying and death, can be uncomfortable. Discomfort discussing dying is universal. We have to face our own fears as patients or family members about what dying might mean. And then clinicians, doctors and nurses also have fears around talking about end-of-life care and dying. And some of that comes from their own fears about their own mortality. Some of it comes out of a concern of their inadequacy to cure people and make them better. And I think that recognizing the discomfort is very important to help us work through it. And I think it's even worth considering talking about the discomfort. This, both as a doctor, saying this sometimes can be very difficult to talk about this, I appreciate your being willing to do that, but also as a patient or a family member, to talk about the discomfort can be helpful as well. So finally, I wanted to finish up by talking a little bit about this new Palliative Care Center of Excellence that we've developed at my hospital at the University of Washington. And I wanted to talk about this because I think it may serve as a model for opportunities to develop similar palliative care centers across Thailand. I know that Chulalongkorn University has developed a palliative care center. I suspect there are others as well, and there may be an opportunity to support those as a way to improve palliative care. The mission for our center is to improve palliative care received by patients with serious illness and their families, and to support clinicians who provide both primary and specialty palliative care. We want to develop new knowledge, educational and clinical resources to improve palliative care in our region as well as nationally, and have these tools be available globally as well. We developed a website that allows us to put our resources up there as well as links and other helpful information, and to keep people in our area aware of what the opportunities are for training, for public education, and so forth. And we really encourage people in our area to get involved. Anybody can join our Palliative Care Center of Excellence as a member, patients, families, doctors, nurses, others, and help to develop or use the resources. We want to make these tools available for people who care for patients with serious illness by providing education in palliative care, as well as resources for patients and families. And we've been very interested in developing community input. We've developed a community advisory board, and there may be opportunities to volunteer for a similar type of board here in Bangkok. We've also developed community forums trying to educate the public about the importance of palliative care and get feedback from the public about things we could do that might help. So then, in summary, what I've tried to cover over the last 40 minutes or so is to talk about palliative care, what it is, and point out that it really seems to be an exciting time for palliative care. Palliative care is gaining momentum in my country. I also see it gaining momentum in this country as well. And communication, I believe, is a really key piece for palliative care. Currently, the quality of communication and palliative care in our healthcare systems is often poor, although I do think it's improving, and I think there are opportunities to help it improve even more. There are interventions for clinicians that can clearly train them to be better at this kind of communication, and I think we need to find ways to disseminate those interventions. We also need to encourage the general public to take steps to move this forward. Encourage them to talk to their doctor and their family, to think about advanced care planning and complete advanced directives and discuss those advanced directives. And then I think the Palliative Care Center of Excellence is an opportunity to really try to increase our ability to disseminate this information within the healthcare system to doctors and nurses and others, but also to the general public. So those are the comments that I wanted to make about palliative care. I would very much like for us to have a conversation. I hope there will be questions and comments from you. I also traveled to Bangkok with Patsy Treese, who is a nurse, an ICU nurse, and a nurse researcher who's been working with me and helping develop these programs. And I'm going to encourage her to speak up and comment on any questions or comments that are raised as well. So thank you very much for your attention.